I'll try to respect my time and be short to the point for the question about DOACS, so direct oral anticoagulant, so anti-2A or anti-10A in the PCI patient. I could stop here. There's not any data now prospectively to really present to you except retroactive. So what I say, I will look into these patients and see what we could do. So these are my disclosures. These are other disclosure about the antiplatelet guidelines, so was mentioned before. Learning objectives. So discuss the DOAC or direct oral anticoagulation and the combination with the newer antiplatelet, because we have data maybe with clopidogrel, but we have almost no data with ticagrelor and prasugrel, as these patients were excluded from the trial if they were anticoagulated. How to balance and minimize bleeding risk, we will discuss that, practical points. Optimize patient-tailored therapy in difficult cases. So hopefully we'll have time maybe for question or discussion. Is that rare? No. I mean, as sure you treat older patients, AFib is increasing, and we have more and more patients on DOAC. So from literature is up to 2 to 21% of the ACS patients that have atrial fibrillation. So it's not something that we see once a month. We see that almost on a daily basis in a cath lab, a busy cath lab. Now again, I'm glad that this was shown a bit earlier by Kevin, but just to say that, yes, we've been told more and more that thrombin is one of the most important agonists to platelet activation. So maybe we could have better antithrombin, then maybe we could have better result of our patients. So anticoagulant have evolved, as you know. Antiplatelet too have evolved. I mean, I think prasugrel and ticagrelor, and mainly now we're using ticagrelor, is much better than clopidogrel. We don't think about it, but the result being better now in literature, because probably we're using those more agent more frequently. Again, if we look at the study, and again, this is from Mike Gibson. It's not from me. I'm not good enough in calculation. But he says that if you look at the dose of aspirin, the duration of aspirin, the different antagonists to ADP, the duration of these ADP, the oral anticoagulation, all these combination makes that at the end, if you permute all that, you have more than 1 million different permutations. So we're confused. I mean, I cannot tell you how I can put that simple. I mean, it's very complex to look at all the different evidence that will be ongoing in the coming months and years. So this is, again, a slide from Mike Gibson. Again, I don't want to read through all that, but a lot of suggestion, a lot of retrospective analysis. Actually, 2 small randomized trials that look into that, the WOOS trial and the ISAR triple, but they're with clopidogrel and they're with warfarin. So they don't instruct us with the DOACS. So again, millions of choices, limited data. So 0 trial with the DOACS and antiplatelet therapy. Ongoing, what people are doing, a lot of people in the field are doing, continuing the DOAC with dual antiplatelet therapy. So I think we have to be careful. I mean, it's doable, but is it safe for the patient? We don't know about the bleeding risk long term. There's been some signal about intracerebral hemorrhage in some of the early trial, or maybe some recurrent MI. Again, we do it because patients don't want to go back on warfarin once they've been on the DOAC. So that's the reality we're faced. So we need, obviously, these randomized trials to evaluate the combination and optimize the safety and efficacy. I won't be able to show that to you today because they're ongoing. So this is a paper also that maybe is worth reading about triple therapy in AFib, PCI. It's from the wild. So obviously, proponent from the WOOS trial about double antiplatelet, double therapy, meaning that 1 antiplatelet and either warfarin, as WOOS was done, or maybe with DOAC, but again, without data, versus triple therapy that over long term, as one shown in WOOS for 1 year, increases bleeding. But be careful, WOOS was a lot of femoral, was also not treated routinely with PPI. So again, you have to face the literature. It's a limited study, it's randomized, a good trial, but we don't have all the information we need to take decision in all our patients. So what did the ESC guideline told us not so long ago in 2015 is that in patient with a firm indication of anticoagulation, be it warfarin or NOAC, obviously if it's AFib, most of them are on NOAC, but if it's a mechanical valve, a lot of them will be obviously on warfarin. Well, we should give triple therapy. We should give dual antiplatelet therapy with oral anticoagulation. That's what they say. Now, we're faced with that patient on our table, returning the patient to the treating physician, and we have all these major bleeding criteria that we would like to lower. Obviously, you want to lower the bleeding risk, but also we don't want to increase the thromboembolic and the stent thrombosis and recurrent MI. None of the data suggests second generation are safe, but at the same time, we do have very complex, multiple, bifurcation, lots of risk factor of having a stent thrombosis. So it's not zero. We do still see stent thrombosis. So what do we do? What do we use? The CHADS-VASc score for the risk of thromboembolic event. Obviously, in the DAPT, stent size was mentioned, as well as the context of having an ACS syndrome that I think carries the risk of thrombosis. Finally, the ASBLED is probably the most recognized bleeding scale. So people are recommending to do both scores and trying to find out what to do with these patients. First thing I say to fellows, I say to everyone is know the patient. Obviously, when it's an acute MI, post-cardiac arrest, we don't have time sometimes to get all the information, but we try to get as much information. If it's elective, please know all the characteristics of your patient that could put him at risk of bleeding acutely, but also chronically. Vice versa, the risk of ischemic. Also, these are the variables that were shown to be related to individually to bleeding. So if you have a patient with several of these characteristics, that increases a lot the risk of bleeding. So you have to shorten the duration, obviously, of DAPT. You have to maybe modify the anticoagulant regime. We'll see that. Obviously, you know that, you're convinced the radial reduces bleeding, so we encourage everyone. But worldwide, there's still a lot of usage of femoral, and in the patient with DOAC, you should consider, or anticoagulant, you should consider the radial access. In this specific population undergoing intervention that have anticoagulation and you don't know the level, you don't know when they took their medication, it is recommended to consider not to pre-treat. We're not talking about those patients that we are elective and we know we can maybe tailor therapy or see how well they're anticoagulated. But for now, I think the recommendation is not to pre-treat that specific population, and that can come up in the discussion period if we have time. Avoid systematic use of dupilumab. I think we use it less and less, but it could be useful when there's clot recurrent thrombosis. But at the same time, with the more powerful agent, then we could avoid most of the case with the dupilumab. Pay attention to the renal function. Obviously, someone on DOAC, as you know, mild to moderate renal failure, not that much issue. But if they're fragile, when they go to the cath lab, they have hypotension, what's going to happen in the next few days? So recommendation will be to continue the DOAC, but I say, wait a minute, watch the renal function, because at some point, yeah, you may continue the DOAC, but if they have renal failure, you may have some bleeding issues. Finally, you could consider in that specific population bivalirudin, but you need to know the acute renal function, because if you have severe renal failure, let's say in a patient that you don't know in STEMI and you start using bivalirudin, you could get into trouble with bleeding too. You think you're going to reduce bleeding, but maybe not in all patients. Finally, chronically, what could you do? Obviously, use PPI, WOOST, only 40% PPI. Reduce the exposure to triple therapy. So we saw that the new generation DS are safer. There's new bioactive stent, biofreedom type of therapy, so we could consider that. Avoid initially, at least, prasugrel ticagrelor unless you define anatomy and is a high risk of thrombosis. Then you have to probably tailor the anticoagulant duration or selection. Warfarin, target INR 2 to 2.5. It's easy to say, it's not so easy to do, but some people are very stable to NIR, and why not continue them on warfarin at this time? The DOACS, what's recommended is to use the lowest dose effective for atrial fibrillation. And then watch the renal function. That's the same thing for chronic use. These are the guidelines. They may be small from the back, but it's just to say that people are trying to say, well, how can you shorten the duration? Well, obviously, if you have a high-risk bleed, has bled more than 3, then you could go away, and this is a non-STEMI population, to about 1 month. Again, not based on prospective data, but on consensus that the risk of bleeding may be too high for these patients, and you would like to have triple therapy for the shortest duration, 1 month. And then after that, you could go dual therapy, anticoagulant, and one of the two agents, either your choice, clopidogrel and aspirin. There's no ticagrelor or prasugrel because, again, these patients were excluded from the trial. We can do it, but it had to have a very good reason. If you have a low has bled, then you could go, as said, 3 to 6 months. But then again, you should consider like a WOOS type protocol. WOOS having either oral anticoagulant with clopidogrel or aspirin. If you medically manage, again, dual therapy, and then you can go with the oral anticoagulation and one agent, that's probably more like a WOOS type of study, although the WOOS had angioplasty in most of their patients, obviously. So that's the HAS-BLED score, you know that. And also, these are the guidelines in more detail, where I think there's some place for controversy. Obviously, you adjust the heparin dose, you use radial, there's no controversy. PPI, perform without interruption. This could be in some way controversial based on the renal failure patient if the patient is under control. It depends on if it's urgent, STEMI, whatsoever. But if it's non-STEMI, maybe it's better to wait a little bit. Also, what to do with the vitamin K and target the INR, more or less of 2.5. This is also to discuss. I would say if you have a DOAC, it's probably recommended to give extra heparin because like we learned from the Fondaparinux days. And again, avoid, if possible, in that specific situation, P2Y12. Now, trials, what are coming? You may know Augustus trial. This will be interesting. Again, these are not huge, but they're kind of 4,600 patient studies, so we should learn from that, trying to answer two questions. What about apixaban versus vitamin K? And what about dropping aspirin? So apixaban with aspirin versus apixaban alone with the other DAP, the P2Y12 inhibitor, and vitamin K with aspirin, again, dropping aspirin. So again, this will be interesting to look into. We can speculate about the result. Same thing with Redial, but a different agent. So what we're looking is at regular high dose dabigatran, 115 milligram BID with P2Y12, dabigatran 110 BID with P2Y12, warfarin with P2Y12 and with aspirin, and dropping the aspirin after 1 month with berometostat, and after 6 months with the drug-eluting stent. So again, complex study, but at the same time, we'll have some data, hopefully, to instruct us for this. Pioneer is probably one also very important trial to look into, looking at rivaroxaban, 15 milligrams, so that's the lowest AFib dose with clopidogrel. Then the other arm will be rivaroxaban 2.5, so that's the Atlas dose, clopidogrel, aspirin, or rivaroxaban after a period that the clinician will decide upfront, 1 month, 6 months, or 12 months. What you would do, that's the protocol that will look into that. And the final arm will be vitamin K, clopidogrel, and aspirin. And again, the duration that the clinician will give. And then you continue only like the WOOS protocol in some way, vitamin K, aspirin. So if you look at that simplified, again, these were not non-STEMI patients. There will be AFib patient undergoing PCI, some of which could be acute coronary syndrome, but not all of them. And this is like a WOOS plus type of therapy, so the oral anticoagulant with single antiplatelet. This is more the Atlas dose, and then continue with the rocket-like dose. And this will be more the control arm, like the warfarin DAP, and then transitioning to like a WOOS standard dose of warfarin and aspirin, or clopidogrel in WOOS. So in conclusion, triple therapy is something to take seriously. It adds to the acute risk of bleeding and chronic risk of bleeding. And bleeding is associated with poor outcome, we know, because at some point the patient bleeds, we have to transfuse him, or we have to interrupt the treatment, which leads to some potential ischemic event. So I think we need to carefully assess that patient at the time, or just hopefully before PCI, but also after. So it's a dynamic assessment over time at 1 month, 3 months, 6 months, 1 year. And obviously there's technical aspect that we can look at, radial, well-deployed stent, imaging to look if the stent is fully opposed, pharmacological strategy I tried to explain to you. At the same time, we have to watch for updated data from trials. So hopefully this answered that difficult topic in some way, that there's a lack of data, and we're there trying to do the best for our patient. Thank you very much.